Welcome to today's review on USMLE topics, and today we are going to be reviewing hematology, specifically platelet disorders. So when we think of platelets, we think of bleeding disorders. So they are involved in primary hemostasis, which is the first attempt to stop bleeding before clotting factors come and then give us some more concrete fibrin clots. Give us some more concrete clots, and that is secondary hemostasis. So today we're going to be talking about all things platelets. So first things, platelets are gotten from megakaryocytes, okay, and their lifespan is about 8 to 10 days. They are made in response to thrombopoiesis, so just the way we have erythropoiesis in response to erythropoietin, that's the same way. So what's important to know about platelets? First things, there are two types of granules that I want you to know. First is the dense granules, and the second one is the alpha granules. So the alpha granules would be, I would say, the most clinically or USMLE relevant because it is where we have von Willebrand factor, it is where we have fibrinogen. We also have fibronectin and platelet factor 4. Platelet factor 4 is going to be relevant for when we talk about heparin-induced thrombocytopenia, because you remember that heparin forms a complex with platelet factor 4, and that is that complex that will keep activating platelets, keep causing thrombosis, and also cause thrombocytopenia because the spleen will now come and clear it away. And then also know that von Willebrand factor is not only gotten from alpha granules, it's also gotten from Weber palette bodies, which we have in our endothelium, right, which is like the blood vessel, right? And then for the dense granules, what we have in the dense granules are calcium, ADP, serotonin, histamine. Remember that calcium is very useful for the coagulation cascade, and ADP is very necessary for platelet aggregation. First things first, when there is endothelial injury, so the first thing that happens is that we have some transient vasoconstriction. So I think about it like, okay, if there is a cut in the endothelium and then we are going to have the bleeding, so the very first response will be, oh, can we constrict this blood vessel? Can we try to limit whatever bleeding that we might have? And that is mediated by the nervous system. So it's a reflex, and secondly by endothelin. This is very important because now making an association with respiratory system in pulmonary arterial hypertension, one of the drugs that we use to treat pulmonary arterial hypertension, especially the primary one, is bosentan, which is an endothelin receptor antagonist. So if you think of if you think of endothelin as a vasoconstrictor, inhibiting it or antagonizing it would cause vasodilation, which is what we're looking for in pulmonary arterial hypertension, right? So that's just an association that I wanted to throw in. Next thing, we have exposure. So the subendothelial collagen that was protected by the endothelium becomes exposed. And when it becomes exposed, something happens. The platelets begin to adhere, and that adhesion would be mediated by von Willebrand factor. So von Willebrand factor is what is going to connect your platelet to the subendothelial collagen. And how does it do that? It does that by the help of a receptor called your GP1B receptor. And that GP1B receptor is found on the platelet. The implication is that there are two things that can impede platelet adhesion. First, if we don't have von Willebrand factor, and second, when we do not have GP1B receptor, which is called Bernard-Soloway disease. So when platelets adhere, they release some factors. They release ADP, they release thromboxane A2, which we get from arachidonic acid. If you remember your COX and your LOX pathway, we get it from arachidonic acid, and it's very important for aggregation. It also slows down the blood flow because we are trying to mitigate blood loss, and heal that area, form a plug in that area. So anything that will slow down blood flow, anything that would help us aggregate platelets there, it's a good thing for us. And then platelets also release ADP. So now what does ADP do? ADP helps platelets adhere to the endothelium, but something else that ADP does is that it binds to a receptor on the platelet called your P2Y12 receptor. And this binding will induce another receptor's expression on the platelet. And this second receptor is GP2B3A. See, I know that these things might be flying over your head, but with constant repetition, you will get it. So we have ADP binding on a receptor called P2Y12 on the platelet, and that binding will now push GP2B3A to the surface. So why do we need GP2B3A? Because that is the receptor that will facilitate or mediate platelet aggregation, which is our next step in this cascade. So that is where fibrinogen, remember, which is produced from the alpha cells of the platelets, that is how fibrinogen would now bind to this platelet, bind to the other one, bind to the other one, and all that binding of fibrinogen. So fibrinogen is like a wire connecting platelets through their GP2B3A receptors, and that's how we have platelet aggregation. So that gives us like a temporary plug before clotting factors come and then give us like a more solid plug. Because we've mentioned a lot of mediators, a lot of receptors, these are potential places for disease if we do not have these receptors, or if something happens to them, or like an antibody binds to them. And this is also a potential place for pharmacology questions, because now we're going to have drugs that bind on these same receptors or inhibit these same receptors. So now let's explore what platelet disorders we can have. So first thing is platelet counts can be decreased, and there are tons of reasons why we would have decrease of platelet counts. Maybe problem with production, maybe some bone marrow problems, in some cases like maybe we have myelofibrosis, or we have chronic lymphocytic leukemia, and the bone marrow is either not producing everything, or pancytopenia is not producing everything, maybe drug, benzene, poisoning, in a plastic crisis or plastic anemia, things like that. The bone marrow says I've packed up, or the bone marrow is busy producing cancer cells, and then because of that, platelets are not produced. That's one factor. And another thing can be in immune thrombocytopenic purpura, which can be inherited, or it can be acquired. In acquired cases, we have it. It can be in acquired cases, we can have it together with some autoimmune disorders like SLE or CLL that we've mentioned. It can even be a drug reaction, can happen when there is a viral illness like HIV, hepatitis C. And what happens is that we have autoantibodies formed against our GP2B3A receptors. And what happens is that we have autoantibodies formed against our platelet GP2B3A receptors, and the spleen clears them out. And because of that, platelet count reduces. So in this case, you're going to see every other cell line will be normal, but then platelet counts will be decreased. Isolated thrombocytopenia, right? And the other problem we can have in platelet disorder would be, I think we already hinted at it, Bennett-Sallois. So this is when GP1B receptor is deficient. We can also have von Willebrand disease. And in von Willebrand disease, there is deficiency of von Willebrand factor. So what happens is that we have problems with platelet adhesion. Now, there is a test that helps us, distinguish when we talking about von Willebrand disease or when is it Bennett-Sallois. Now, first things, I didn't even mention that when we have platelet disorders, we are mostly going to have skin and mucosa bleeding. So that's mucocutaneous bleeding. So things like petechiae, bleeding from the gums, after tooth extraction, bleeding refuses to stop. If it is in a woman, we are going to have heavy menstrual bleeding, so things like that. They hint you that this is a platelet disorder. Unlike when it is a coagulation cascade disorder, we are expecting to see deeper, like bleeding into cavities, into organs. Like for example, in hemophilia, we're expecting to see bleeding into joints, hematrosis. So if you can make that distinction in your head, it will help you know, is this a platelet disorder bleeding or is this a clotting factor bleeding, right? So let's move on. So you remember that we said that in von Willebrand disease, in Bennett-Sallois, the problem is the same. We are not having platelet adhesion, right? Because the von Willebrand factor that was supposed to connect subendothelial and subendothelial collagen to GP1B receptors on the platelet is missing, or even the GP1B receptor is supposed to be like the receptor for adhesion is missing. So how do we know which one it is which one? So laboratory wise, or on blood smear in Bennett-Sallois, we can have normal platelet count, or we can have decreased platelet count, and then the platelets are big. So we have like big looking platelets. The second hint would be a test called ristocetin assay. So they would like to bring this in your step questions, and then you will see somebody, they would describe bleeding, maybe a young girl, she's 17, she has dysmenorrhea, heavy amenorrhagia, her bleeding, her menstrual cycle lasts up to 7 days. She had tooth extraction a few years back, and the bleeding took a while to stop. Now she's having epistaxis, and they are pinching her nose and it's not stopping. They're giving you that, and they remember that it's autosomal dominant, von Willebrand disease, and so it can affect both boys and girls. So they would throw in a boy, they would throw in a girl, and then they tell you that on ristocetin assay that nothing happened, right? There was no platelet adhesion or agglutination. And then when normal plasma was added, platelet adhesion, agglutination happened, and they're asking you which disease is it. So now remember that this is a person who is deficient in von Willebrand factor. So if you bring normal plasma that contains von Willebrand, it would correct, and then there will be platelet agglutination. Whereas in Bernard-Salloy, because the problem is not von Willebrand factor, the problem is a receptor. So even if you bring a normal plasma which contains von Willebrand factor, there is no receptor on the platelets to bind, so there will still not be any agglutination. So you can replay this, over and over as much as you need to learn this concept, because it might just be the reason why you would get one question. Now it's also important that I mention at this point that von Willebrand factor is a carrier protein for factor 8, which is deficient in hemophilia. So this is why in the labs there will be something peculiar. So usually when it is purely a platelet disorder, the only thing that is increased is the bleeding time. PT is normal, PTT is normal, because we're not talking about clotting factor deficiencies. But in von Willebrand factor, not only is bleeding time increased, PTT will also be increased, because remember, von Willebrand factor is a carrier molecule for factor 8. So if von Willebrand factor is deficient, the half-life of factor 8 decreases, and that can also increase the PTT. How do we treat mild von Willebrand factor disease or mild hemophilia A? So there is this important drug called desmopressin, which is an ADH analog. ADH is antidiuretic hormone, which you would expect to see in diabetes insipidus, but it also comes to play here. And what does it do? Remember that we said that von Willebrand factor is stored in granules, in a platelet. So what desmopressin does is that it increases the release of von Willebrand factor and factor 8. Right, so that is why it can be used in mild diseases. And then because it is an ADH analog, it also places aquaporin channels on the principal cells of the renal collecting duct and distal convoluted tubule, that helps us to reabsorb water, and helps improve the symptoms of central diabetes insipidus. And because of the same factor, it can be used in nocturnal enuresis, where the problem is that a child is peeing, or somebody is more than 5 years is bedwetting, urinating, there's loss of control in the night and they urinate. So if you can cause increased water reabsorption, you would reduce the urine production that would cause the bedwetting. So this is like an integration with the renal system that you want to keep in mind. The next disorder we're going to talk about is Glanzmann thrombocytopenia. In Glanzmann thrombocytopenia, the problem is that our GP2B3A receptor is deficient. We don't have it, so we cannot have platelet aggregation. Now, remember that we mentioned earlier that when there is autoantibody formation against GP2B3A, we have immune thrombocytopenia. In this case, when it is deficient, now we're having Glanzmann thrombocytopenia. Okay, so the problem here would be decreased platelet count and increased bleeding time. Now contrast all these with DIC. In DIC is a consumptive coagulopathy where there is widespread or uncontrolled activation of the coagulation system. DIC doesn't happen unprovoked. It's usually in response to trauma, response to transfusion reaction, placenta abruption, amniotic fluid embolism, acute pancreatitis, sepsis, scorpion, venom, snake bite, things like that. And then we have uncontrolled or widespread coagulation, coagulation activation, and because of that, platelets will be decreased. So platelet count will be decreased, and if platelet count is decreased, bleeding time is increased. But then at the same time, we also have our clotting factors being used up. So at the same time, PTT would be increased, thrombin time will be increased. Everything is increased apart from platelet count and the clotting factors. Right, so contracts that. And then also with uremic encephalopathy or uremia. Uremia causes some platelet dysfunction. It's a functional problem. So nothing is wrong with the platelet count. The platelet count is fine. However, it can adhere, it can aggregate, so we have issues with platelet activation, adhesion, aggregation, but the count is fine. So anytime that you see someone who is a CKD patient, they might not tell you CKD, they might just give you increased levels of BUN and creatinine, and then you're seeing some bleeding disorders, skin bruisings, things like that. You want to keep uremic or uremia-induced platelet dysfunction as a differential in your mind. To wrap this up, let's talk about the pharmacology integration of all this. We already talked about desmopressin, which would increase the quantities of von Willebrand factor and factor 8. We have drugs that inhibit P2Y12 receptor, which is that receptor that ADP binds that helps us to have platelet aggregation. So drugs like clopidogrel. So think about it. In what cases do we want to inhibit platelet aggregation? Maybe in MI, you hear so much about dual antiplatelet therapy. This is when we have like aspirin plus clopidogrel, most commonly. So maybe prevention of stroke, and then I already mentioned aspirin, so let's talk about it. Aspirin is a COX inhibitor, and if you inhibit COX, we don't have thromboxane A2, which we already talked about, is a platelet aggregator or is a mediator of platelet aggregation. So that is also one of the drugs that can be used to inhibit platelet aggregation. Now, the other group of drugs we'll talk about are your GP2B3A receptors. Same thing, if we want to inhibit platelet aggregation, we can also target it at the level of the GP2B3A receptor, which is the receptor responsible for mediating fibrinogen-mediated platelet aggregation. So an example of this drug is abscessimab. Okay, since we mentioned ITP, we can also mention TTP. TTP is thrombotic thrombocytopenic purpura, if I'm not mistaken. So it has some significant overlap, at least in name, with ITP, because there is also thrombocytopenia. But the problem in TTP is that, von Willebrand factor is made as multimers. So there is a protein in the body called ADAMTS13 that is responsible for cleaving von Willebrand factor, because yes, we do want thrombosis in cases where there is endothelial damage or in cases where there is bleeding. But then we also have, measures in our body to make sure that, these things do not go above and beyond, beyond what we need. So ADAMTS13 is a molecule that cleaves von Willebrand factor. So in TTP, it is deficient. It can also be inherited. It can be acquired, maybe onto antibodies against it, So in this case, we have von Willebrand factor existing as multimers, and this would cause widespread thrombosis. And the thrombosis will almost always usually occurs in the small vessels. That is why it is called microangiopathic hemolytic anemia, MAHA. And this thrombosis would deplete platelets, so we have thrombocytopenia. And also, as our RBCs are passing through this thrombi, your endothelium, endothelium that is full of thrombi, it can, because of this shape destruction, it can share these RBCs, causing hemolytic anemia. So in that case, you also have hemolytic anemia. So you're going to see things like increased LDH, decreased serum haptoglobin. You can see hemoglobin in the urine, pallor, scleral, conjunctival, jaundice, yellowing, things like that. Just something hinting you that it is that there is jaundice or hemolysis. There is also fever in a few cases. In some cases, we have renal impairment, so increase in creatinine. And in some cases, if this happens in the blood vessels in the the blood vessels in the brain, we can have neurologic symptoms, right? So now that I talked about TTP, it is important that I bring this tie in hemolytic uremic syndrome, which usually happens after ingestion of food contaminated by E. coli. And so you see a child who had diarrhea or GI symptoms, they traveled, after traveling, they ate maybe street food or something like that. And then there's diarrhea. And then after diarrhea, one tells you that 2 weeks later, this child is tired, fatigue is a sign of anemia. There is pallor, skin pallor, mucosa pallor is a sign of anemia. And then they give you symptoms, maybe anuria or increased creatinine or increased blood urea nitrogen, hinting you that there is renal impairment, and then they tell you about schistocytes, hemolytic anemia, So this is hemolytic uremic syndrome, where we have a triad of hemolytic anemia, we have thrombocytopenia, and you have uremic symptoms. So thrombocytopenia, because of that widespread thrombosis, it's kind of the same thing happening in TTP, just that in TTP we have a pentad, while in hemolytic uremic syndrome we have a triad. So hemolytic anemia, thrombocytopenia, uremic symptoms. So hemolytic anemia, thrombocytopenia, uremic symptoms, that's a triad for HUS, for horse. And then when we add fever and neurologic symptoms make it a pentad, it becomes TTP. But just bear in mind that in TTP, it's not compulsory that all 5 things are present for it to make a diagnosis. If you see hemolytic anemia, you see thrombocytopenia, and there is decreased ADAM TS13 levels, it's enough to make your diagnosis of TTP. And yeah, with that, we come to the end of our review of platelet disorders. And I'll see you guys in the next one. If this review was helpful for you and you would like me to, keep making more of these videos, please consider subscribing to my channel if this is valuable for you. I'll see you guys in my next one.